coming out on such a cold night to attend. I'm Jerry Champlin from the League of Women Voters Comal Area, and we're very honored tonight to have Dr. Emily Briggs here. She's a distinguished family physician and healthcare advocate to talk to us about maternal health and how and the challenges that the laws and policies in Texas pose to providing safe and comprehensive health care in our state. Before Dr. Briggs starts, I just do want to mention we're being taped. We're taping the program so that we can post it on our YouTube channel. And also a few reminders about what the Comal Area League is. We are an all-volunteer, nonprofit 501c3. We are always nonpartisan. We never support or oppose any political party or candidate. The League is committed to fostering, cultivating, and preserving a culture of diversity, equity, inclusion, access, and belonging for all people. Our mission is to empower voters and defend democracy. And with that, let's welcome
I apologize for being behind a podium, but it's easier for me to see my notes this way. And you'll catch me with my lovely, what I call in my office, my old lady specs, just so that I can see better. So yes, Emily Briggs, I'm a family doc here in Braunfels. I've been here for about 15 and a half years. Hung my shingle after finishing my residency and was very happy because I was in the San Antonio area, had to be close to the Spurs, but I wanted to be outside of a big city. Found in Braunfels, and at that time, many of you know, we just had one hospital, and it was a lovely town to come to. And since then, I've raised two children, and one of them is in college, and the other one is at one of the high schools here. So definitely a local girl now. My 15-year-old has only known New Braunfels, and so we're happy to be part of this community. This information, I'm going to start with what our current situation is in Texas for maternity care, how we have access to care and how we don't have access to care. And then I'll go into the political landscape to a very small degree, just in the case of comprehensive medical care. And so I work with the Texas Academy of Family Physicians, the Texas Medical Association, and in that information, I was able to gather some information from Torch, which is for all of the rural hospitals in Texas, along with March of Dimes, the Commonwealth Fund, health landscape maps from the Robert Graham Center, which is what the American Academy of Family Physicians puts together to have maps of all of the United States, drilled down depending on the qualification. So you'll see some of those maps in a little bit. When I'm talking about OBs on some of these maps, that includes physicians like myself as a family doc that delivers babies, obstetricians. It also includes midwives, both certified nurse midwives, lay midwives, and really the gamut of people delivering babies in Texas. And so some of this information is from a 5-year survey that was done from 2013 to 2017. And so, just to start with talking about the distance to maternity care, 4.6% of Texas women have no birthing hospital within 30 minutes. In rural areas across Texas, 28.4% of women live over 30 minutes away, compared to only 3.8% if they're living in an urban setting. Women living in maternity care deserts travel 4.5 times farther than women living in areas with full access. So nearly half of Texas counties are maternity care deserts, compared to only nearly a third in the United States. And that's information from the March of Dimes. Still from the March of Dimes, 20.4% of Texas women giving birth receive inadequate prenatal care, which is greater than nationally at 14.8%. Our Black, Indigenous, and people of color, that's how the March of Dimes describes this population. 4.9% did not receive prenatal care in areas of high socioeconomic vulnerability. And among that population, those living in those areas have 44% increased likelihood of inadequate prenatal care compared to people that are living in low socioeconomic vulnerability areas. So when you look at this Texas map, this was put together by TORCH, the Texas Organization of Rural and Community Hospitals, and it's maybe difficult to see from the back, but you might be able to see better the colors. So just to highlight, the colors that are rural hospitals without labor and delivery are the orange counties. The blue counties are rural areas with labor and delivery. So you can see so many of those are, we have the I-35 corridor that you can see down in the blue. You can see some areas that have, or right next to the blue, I should say, you can see the white that is the I-35 corridor, which is right here. And so you can see how well populated that is, not only by humans, but also by hospitals and by care teams. When we get out from there, the yellow areas are rural counties that don't even have a hospital. So you can see just how parts of Texas are already being affected just looking at the TORCH data. So statewide, 21% of women between the ages of 19 and 64 did not have health insurance in 2022. You might think, well, health insurance, you don't have to have health insurance to have access to care, but that really is a proxy that we use to define whether people have access to care. Beginning in March of last year, Texas has extended the Medicaid program to have postpartum coverage instead of 6 weeks postpartum to being 12 months postpartum, which is so very important because a lot of our morbidity and mortality does not happen right at the time of birth. It happens within that first year postpartum. So it was a huge win for those of us in advocacy. We've been fighting for that for literally a decade, and we finally got the Texas legislature to approve of extending Medicaid for 12 months. And so prior to or between pregnancies, women can now obtain basic preventive health care services through the Healthy Texas Women Program or the Family Planning Program, which are two different programs depending on whether you are a United States citizen or living in Texas. Lack of access to comprehensive, affordable health care throughout their lives is one of the top reasons women forego preventive and primary care before pregnancy. So building on House Bill 12, in its 2024 report to the legislature, the state's Maternal Morbidity and Mortality Review Committee's #1 recommendation is to provide women comprehensive health care throughout their reproductive lifespans. And you can see some of these other statistics. So I'm not a person that likes to read slides to people. I give you a chance while I'm talking to feel free to read some of those statistics. So this is one of those health landscape maps by the Robert Graham Center. This is in February of 2019, and this is identifying all OBs and family medicine physicians and providers, including birth centers and hospital locations. So for everybody to be able to see, again, pictures are better for me than trying to read those words. The little dots are hospitals or birth centers. The darker the green, the more populous that area. So just to give you an idea. So this is how many or where the birth centers and hospital locations are. Again, you can easily see that I-35 corridor, just to give you orientation to where we are. You can easily see the Dallas-Fort Worth area, the Houston area, along the border, and El Paso. So those are some of the more populous areas that we anticipate seeing. When we then take away the hospitals and look at where are the physicians, where are the providers of care, the little dots you'll see, the darker colored dots are family physicians, and then the yellowish, orangish color are OBs. And again, OBs include lay midwives as well as lay midwives, certified nurse midwives, and obstetricians. So important about this, again, you can see where some of those areas are that are heavily populated by care, not necessarily by people, but by care. Again, the lighter the green, the lower we have number of providers in that area, the darker the green, and now you can see where those offices are. But you can see that there's a lot of coverage of Texas. The gray zones are where there's nobody. There's no hospital, there's no physician. No outpatient practice, no birthing center, no nothing. So that's where these gray zones are, okay? Family docs, though, compared to obstetricians, as a family physician, I provide care, we say, from cradle to grave, or from the beginning of life to the end of life. So there's more of a comprehensive nature to that care when you have family physicians involved. And I say that because when you then just look at where OBs are, and again, this is lay midwives, certified nurse midwives, and obstetricians, look at the gray. We don't have, this is not counting the family docs, this is just the OBs. You can see the gray is a lot bigger. You can see where the hospitals are. So those hospitals only have family physicians delivering babies, which I think is pretty fine. But that means that there are limited access to care there because I have a lower acuity ability because I'm not a specialist and only delivering babies. I take care of people with hypertension and asthma and diabetes and all the rest, and not just delivering babies. So in those areas where you see hospitals and you don't see any OBs, they can provide lower level care, but not that higher level care. They're not the tertiary care centers. Now, if you look at where the offices are, do you see any yellow? None, right? We have OBs, that includes lay midwives, birthing center midwives. They don't go out to the areas in the middle of the gray area. They're along the I-35 corridor. They're in Dallas-Fort Worth. They're in Houston. They're in, Amarillo. They're in El Paso. They're on the border. But they are not in the areas of Texas where we have these deserts. So just to remind you of the difference in that color, right? That is where we have that comprehensive care, but even then we have these gray areas. So you can really appreciate that issue. So looking back to a decade ago, the Texas Morbidity and Mortality Report remained remained relatively stable. From 2013 to 2017, we had somewhere between 18.3 to 20.7 deaths per 100,000 live births, which then decreased. We had this nice line, and then it started to decrease in 2018 and 2019. And then in 2020 and 2021, it dramatically increased to 27 to 37 deaths per 100,000 live births, due in part to COVID. But even if you take out those COVID numbers, we were still at 24 to 24.2 100,000 per 100,000 deaths in 2020. So we have maternal deaths really accounting for a tragedy in Texas.
What was the cause?
So that is all-cause mortality around maternal care. So the primary one, if it is within the time of labor and delivery, not accounting for the year after that we now cover, that's mostly hemorrhage and heart-related conditions. As we look further out, when we get to that 12-month and looking in that time, from about 6 weeks to about 12 months postpartum, we're seeing more of substance use disorders affecting the death rate for maternal death rate. Yeah. But as you can imagine, the acuity of hemorrhage is more in that first time and heart disease. So that's where we are. That's Texas. That's without any of these newer rules that have come into place. That's just maternity care deserts. So, now let's talk about some of the other things. Currently, there are 2 abortion bans in practice in Texas that were put into place in 2021 and 2022. So the trigger ban, this is Texas's most restrictive abortion law, which bans all abortions except when the mother's life is in danger. Quote, the trigger ban took effect in August of 22 when Roe v. Wade was overturned by the U.S. Supreme Court. Medical professionals found in violation of Texas's trigger ban can face criminal, civil, professional penalties, including a minimum of a $100,000 fine, minimum, medical license being revoked, and up to life in prison. That's the trigger ban. Then we have Senate Bill 8, which came effective in September of 2021, known as the Heartbeat Act. Senate Bill 8 prohibits abortion once fetal heartbeat can be detected, typically around 6 or 7 weeks of pregnancy. So though Senate Bill 8 outlines an exemption, should a pregnant woman face an emergency that requires an abortion to save her life, the law is written so that in practice, such exemptions force women into precarious health situations that can lead to death, even if there is, but often when there is not a medical intervention. Violations of Senate Bill 8 are not punishable as crimes, but rather enforced by a civil bounty hunter enforcement idea, which allows any individual whether or not they have a connection to the patient or the provider of that care, to bring a civil lawsuit against the medical provider and anyone who aids and abets an illegal abortion, which could include something as simple as giving a person a ride to a place that provides abortions or a ride out of the state. Successful bounty hunters are eligible for a $10,000 reward and attorney's fees. So it's very effective. Together, the trigger ban and Senate Bill 8 create an abortion ban from conception. The only exception is when the mother's life is in danger. However, it is challenging for a doctor to determine how dangerous the situation must be for that doctor to ensure that they won't be penalized for addressing the situation. There are no other exemptions, including for rape, incest, or lethal fetal anomalies. So, in May of 23, in response to complaints from doctors, from patients, from community leaders about the law's lack of clarity, the Texas legislature passed House Bill 3058, which provides medical professionals an affirmative defense if they perform a medical abortion in the case of two specific pregnancy complications, one being ectopic pregnancy, and another being previable premature rupture of the amniotic membrane, which is the bag of water the baby is otherwise inside. However, the laws do not cover additional medical emergencies that might require a pregnancy to be terminated as part of best medical practices, evidence-based care. Across all Texas abortion laws, a pregnant woman is explicitly exempt from liability and prosecution. So that at least is a plus out of these bills. So, what exemptions apply in these laws and why do they lack clarity? Well, both the trigger ban and Senate Bill 8 include exemptions for quote-unquote medical emergencies, where physicians, in the exercise of their reasonable medical judgment, determine that a pregnant woman is suffering from a life-threatening condition that, unless abortion occurs, is at risk of death or substantial impairment of a major bodily function. Those are the terms that are used, and that's why I put it in this format. These laws do not clearly outline what qualifies as a medical emergency, what is life-threatening, or substantial impairment, nor do they define what a major bodily function is, which makes it very hard for the medical professionals to properly provide care to pregnant women. This ambiguity endangers the lives of Texas mothers because doctors, amidst this uncertainty and the threat of life in prison, may delay or even deny care because they're unsure if the patient indisputably qualifies for these conditions. Furthermore, many hospitals, fearing legal liability amidst the law's ambiguity, have increased restrictions on when they allow a doctor to terminate a pregnancy or provide that care, putting women at risk of undue medical complications. And we've seen this in the social media, people having comments about this. So I wanted to put some real-world examples in here, just for instance. So current laws have interfered with critical health care for pregnant women, including life-saving treatment for pregnant mothers diagnosed with cancer or other health issues. The choice to terminate a non-viable twin to save the life of a healthy twin. A doctor's ability to provide full information to pregnant mothers about their health care and to treat them with long-standing, life-saving, safe, and medically recognized standards of care. I have colleagues with experiences of, with myself as well as my colleagues, inability to provide what we consider informed consent. So the definition of informed consent is being able to provide all options for a treatment plan. And if you cannot speak to part of that care, you can't effectively provide informed consent. And that is the basis of our medical care, that we have the patient sign that they've received informed consent, and that we sign that we gave informed consent. So comprehensive portrayal of the impact of these laws on women who want to have babies. You can see that on ABC's On the Brink, which is a documentary on Hulu, which includes heartbreaking stories of 6 Texas women with pregnancy health complications. Most of us Texans watched the Supreme Court deny Kate Cox the right to terminate her non-viable pregnancy, forcing her to leave the state to receive treatment. We have heard disturbing accounts like that of Amanda Zarowski, who almost died from a miscarriage because her doctors didn't believe they could intervene under Texas's Health of the Mother exemption. Another Texas woman miscarried in the lobby restroom of an ER when the ER refused to check her in for these same reasons. And additional alarming stories involving Texans are covered in the Washington Post and in the New Yorker. So why is this important? Confusing and redundant Texas laws force doctors into impossible situations where they must choose between complying with the law, which could result in a malpractice suit, or providing the best care for their patients and risk life in jail. Under current laws, medical professionals face serious legal risks, including that minimum of $100,000 civil penalties, civil suits by strangers with no connection to the patient, loss of medical license, criminal penalties up to 99 years in prison. These risks deter skilled healthcare professionals for practicing in the state and limit their ability to offer safe, comprehensive care that prioritizes the patient's needs. The legal environment in place creates ethical dilemmas for doctors, compromises the quality of medical education, and delays care in cases of immediate risk. Texas already has a high maternal mortality rate for the United States, and current laws threaten to drive deaths upwards, as research shows that mothers living in states that banned abortion after Dobbs were up to 3 times as likely to die during pregnancy, childbirth, or the postpartum period. Additionally, Texas laws have also heightened infant mortality, which increased by 11% overall and 21% for infant deaths caused by severe genetic and birth defects in 2022 over the previous year. Furthermore, these bans pose a great threat to our state's economic, intellectual, and health outcomes. I've been talking with some people even in the audience. For example, UT Southwestern reported a 30% decrease in applicants to its OB-GYN program over the past year. 30% decrease in those applicants. And before I continue on from that, in talking with some of the program directors, the applicants that they're getting are not necessarily those high quality applicants now, because those high quality applicants go where they want to go. And why would they want to come to a state where they can't provide evidence-based comprehensive care? As the state already has substantial maternity care, maternal care deserts, with 60% of rural Texas hospitals lacking obstetric services and 55% facing immediate closure, we cannot afford exacerbating this healthcare crisis. Current laws are also preventing top talent from coming to work in our state, as a survey found that 2/3 of college-educated adults in the workforce say that Senate Bill 8 would discourage them from even working in Texas. These aren't just people providing the medical care. These are young adults choosing where they're going to live and raise their family. If they are of reproductive age, they're choosing not to come to Texas because they don't want to be caught in a situation that is unhealthy for their own care. Without clear guidelines and assurances for medical professionals, many doctors may hesitate to practice in Texas, fearing potential legal repercussions for providing essential care to patients in critical situations. This hesitation could lead to a shortage of qualified health providers, straining the state's healthcare infrastructure, and compromising access to vital medical services for all Texans. We have an opportunity here to make some changes. We all have a voice. This is the time for us to get as much education on these subjects, to be able to have the numbers for those that want the statistics, to be able to have the stories for those that want the heart-touching component. Legislators listen to their constituents, and so I'm very glad that you guys are coming together to be able to get this information, to then distribute this information out to the community and beyond. And people are listening. I highlight this picture because it really just is so dramatic how when you're looking at it, you can just see with your eyes half of Texas, more than half of Texas's counties, but half of Texas population has no care where we need that care. As some of you know, I had the opportunity to speak at a national level on that 60 Minutes episode, and the reason I was asked is that over the last decade and a half, maybe 2 decades, I've been going to the state legislature. I've been going nationally and talking where people would be listening, and sometimes where they're not listening, because that's what we need to do. We need to let them know what the issue is, boots on the ground. When I'm having to counsel a patient that is in the worst possible part of their life from their perspective. They have perhaps a happy family, they're pregnant, and they want this pregnancy, and something tragic happens. And I can't counsel that family appropriately for the care that that family deserves. That's a tragedy. That's a travesty in Texas. But we have hope. People are starting to listen. People in power, sometimes they turn a blind eye, but they are starting to listen. Because of that 60 Minutes episode, and before it even aired, because of the organized medicine stuff that I do, I got to hear that those who had proffered Senate Bill 8, and some who had pushed Senate Bill 4 and Senate Bill 8 through, were listening. They don't like the idea of their name being dragged through the mud and that they set up this bill and it doesn't make sense for Texas. So now they're talking about listening and seeing how they can make change. There are a few different boots on the ground groups who are quietly providing coalitions and going behind the scenes to have quiet conversations, not in the media, because when you get in the media, there's grandstanding and people have to look good, but behind those closed doors where they're listening to these stories. Because everybody has a mother, sister, niece, neighbor, someone who has been pregnant before. We all came from somebody. We have these experiences, and that is how to make the change happen, is to remind these humans who are human, sitting in places of power, that their humanity demands that they make this better for Texas. And so I have an interesting quote from Lieutenant Governor Dan Patrick on January 19th, 2025. I do think we need to clarify angry language so that doctors are not in fear of being penalized if they think the life of the mother is at risk. We've got him saying that on Inside Texas Politics. Now, no Republican senator has yet to file a bill to accomplish this goal, but his comments are an important indicator that maybe we can have progress this legislative session. So I wanted to make sure to give you that landscape and really open it up for questions and direct experiences and how I can help you to be that voice for our local community and beyond, because your voice matters so very much. So.
Well, if there are no bills, do you think there are going to be some bills introduced?
I anticipate that there will be clarifying bills that will amend our current bills. I anticipate that happening because of the discussions that are happening behind closed doors.
And what would they have to say to make it, or do they have to do a laundry list of, like, they had those 2 things, they have to have a list of 100 things, or what do they have to say to make it clear?
That's a great question. So, in my opinion, a laundry list is just that, and is limited. So rather than a laundry list, trust the physician who has years, decades of medical experience, boots on the ground experience, but also medical experience, medical knowledge, to be able to tell what that nuanced approach needs to be for that one individual patient. But leaving that language open to say it is the medical professional's decision based on their medical knowledge of what needs to happen. Even the board chair of the Texas Medical Board, Dr. Zafran, he is in an appointed position. He's not elected into that position. He has had great angst over this because he actually was quoted as being involved in the House bill that clarified for ectopic pregnancy and for PPROM. The difficulty is when you start listing items. Well, this woman has maybe some of this, but doesn't have the rest of this. And this patient had, so there's too much nuance in medical care. So rather than a laundry list of items, it would be more effective to rely on science, which I know we have difficulty, lately relying on science in a social capacity, but relying on science and relying on the medical professionals' professional judgment.
Do you have any reaction to our governor's comments the other day that he just wasn't quite sure if this had been clarified?
So,
What did you say? What did the governor say?
I don't have a quote to give you,
I
but
can't give you an exact quote, but his basic message was, he just didn't know if this language had been clarified.
Oh, right.
that there have been comments at the legislative level of, well, these doctors are just making a big thing out of nothing. If they would just, pay attention, then they could, make this whole thing go away. They're choosing not to provide that care because they just don't want to, or, My response would be the same response as organized medicine, that absolutely no, that is not the case. That we really, when you put a person's livelihood and my family is dependent on my ability to put food on the table. And so if my livelihood is at risk by providing care that is evidence-based and all of the things say yes, but my hospital can't even say, we'll stand by you. So we've had physicians, and I have lots of anecdotal evidence, but we have had physicians say that they are going to provide this care. They ask the ethics department of the hospital to come in. They ask the risk department of the hospital to come in. And everybody has a little powwow quickly because often these situations go sour fast. They have that powwow and the physician says, okay, well, evidence-based medicine says I should do this. The ethics department says, you know what, that really looks good. We think that you should do that. And the risk department says, you can do what you think is right. But when it comes to somebody coming down on you afterwards, we're not standing by you. So do what you think is right, but we're hands off. That is a terrifying place to be as a single individual physician making that decision. So we do what we can do, and ethically, we try to make sure that we're doing what allows us to close our eyes at night and feel comfortable.
Are there restrictions on what you can actually say to a patient?
100%.
Yeah.
We
That's
cannot
really
speak to a patient about those issues. If I have a patient that comes into the office and wants information about anything having to do with elective abortion, I cannot even speak to that patient or family about such an issue. And unfortunately, these things happen. These topics come, or these cases come into family medicine offices, they come into OB offices, they come into pediatric offices, and we can't speak to what those options are because that's the aiding and abetting. Even giving information is aiding and abetting. And the bounty hunter, Senate Bill 8, precludes us from being able to.
That bounty hunter portion of it, I think, is especially chilling.
Yes.
Do you know if there's been any use of that bounty hunter? Have people received money? Where is that?
I don't know if anybody has received that money yet, but there have been many cases that have already been brought forward of these bounty hunter individuals.
I think people have used it to make sure that people knew they were at risk. Yeah, just as in their basis.
Right, because the fear is far worse.
There was, there was a case, there's a particular anti-abortion law lawyer. This is a woman that got divorced. Her friends had helped her obtain certifications in the use of marriage. She had an abortion, the doctor did the thing over the phone. She had an abortion. He found out about it. He sued in civil court against the two women. That was something that they brought up. They got thrown out because of the text messages. You could see what he was doing was harassing, sexually assaulting her, a bunch of other things. And then right now, Paxton, they're trying to get that doctor, extra doctor from New York, that aided them that by providing side tech to a woman via telehealth. She mailed it to them. So they're trying to bring the ComStat Act back. So if you have the ComStat Act, you're not gonna be able to mail a clearance file, I guess, blue material, I guess, and the most serious is gonna be something that they're going to target where you can't mail. There's two abortions, RU-46 and Cytec, that they take orally, and then when they take it, they can terminate a pregnancy. But they're targeting that, they're targeting birth control, they're targeting after abortion, after Plan B and stuff like that, because they're saying that there was a bill that was trying to be clarified, I think, that said that a couple of the states that black beacons at conception, so it's becoming more progressive. And it's been passed in those official laws.
You know, again, hearing your stories and my niece who's going to GYN, do you even feel comfortable telling a patient they need to go out of state?
So I cannot share with that patient that that's even an option, because that's aiding and abetting by saying, New Mexico has that as a possibility, or I cannot speak to that.
I told Dr. I told Dr. Briggs before, my niece is an OB/GYN, and I just heard from her about a case. She's delivered over 11,000 babies in her career. She got into OB/GYN because she wanted to deliver babies. She feels very frustrated right now. She just had a case where she could not provide the treatment, and she knows it's a non-viable pregnancy. The woman is in great danger. She probably, they would have a great deal of difficulty even removing, if they let the fetus grow anymore, removing the baby even with a cesarean. And she said, I can't provide her treatment in Texas. And it sounds like she can't even say to her patient.
She cannot tell that patient, without risk of the civil penalty, she cannot share with that patient what those options are, because that would be aiding and abetting. And
yeah, that's incredibly challenging.
when it's something, especially, as I commented, a fetal anomaly, you become part of the family when you're walking with them through a pregnancy. And when we have something like that, it's already such a tragedy.
And these are women who want to have a family.
Certainly.
And, if they survive, they may not be able to have babies, right?
In the future. We've had women who lose their fertility because they either lose their uterus or their uterus has become so infected that it is not viable in the future for future pregnancies. So there are just so many tragic situations that we hear about literally every day. The ACOG, the American College of OB/GYNs, has a portion of their website dedicated to tell us your story so that we can help to get these stories out in a HIPAA-compliant way so that people realize, because so much of of those who are in agreement with this law continuing to be the way that it is, say it's not affecting anybody, that this is affecting people who are bad people or who have made bad choices. And that's so uncomfortable for me to hear or even speak to. When you get these stories and you share with them these stories, these real life stories, it's not a socially, it's not an evil person that's having some terrible situation. It's our neighbor. It's our you were going there. Yes.
Oh, I was just curious what it would sound like for that conversation. How do you navigate the conversation when you can't give options, but still establish that trust in the patient?
So the focus becomes what I can do. I can provide a shoulder. I can provide nurturing comments, and I can tell her what medical care we could provide, which is usually very limited. And then when she asks, well, if I need to terminate this pregnancy or where do I go, I have to be very clear and say, actually, I can't talk to you about that at all. And I have to close down that conversation. Just recently, unfortunately, and I won't say how long ago it was, we'll just say very recently, a patient of mine came in and had a situation where she was in need of that care. And she probably in our conversation asked me 20 times, how can you help me get to this next step? And it is unbelievably painful to not be able to share with somebody who you care deeply for what would be the life-saving way to help her care move forward. This is in an age, especially after the pandemic, when physicians are already feeling burnt out because science has been smacked in the face, ethics have been smacked in the face. This is such a difficult time anyway to continue to be a physician providing care. And as I commented earlier, being in New Braunfels for 15 plus years and being a physician for longer than that, you become, your patients become part of you, you know? And so to walk with them through their lives, I've had patients, I saw a patient today who's in her 30s, who started out seeing me when she was a teenager, a young teenager, and here she is, has a family. When she goes through that situation, it will be like I'm counseling my own daughter, or like I'm counseling my sister, and that is heart-wrenching. So we're seeing physicians drop off and being unwilling to be physicians anymore, especially in obstetric care. But it's not just obstetric care, because if you're a family doc that doesn't deliver babies, you still have patients that come into this, and they're gonna ask you what your opinion is, your medical opinion, because they trust you. So to get to that point, it's all about trust. And this Senate Bill 8 removes a big fat component of that trust, because I cannot counsel a patient on informed decision making.
So it seems like in my opinion, the ideal thing would be if those laws didn't exist at all. But is the right thing to try and do these little tweaks to make it a little bit better, or to try to overthrow the whole ban on abortion?
So with the Supreme Court being the one that overturned it, it makes it very difficult in this current legislative session and over the next, we'll say, 4 years, for that to change. I don't see that changing. What we can then change is, rather than throwing the baby out with the bathwater, no pun intended, making it so that this gray zone is clarified, so that at least in situations where we could help that woman's medical care to give us that
The doctor
opportunity.
doesn't have to be that uniform.
Yes.
Right.
Yes. So we need to take the fear out of the medical care.
I mean, I can add an anecdote that my daughter, who is of childbearing age, she isn't planning to have a child anytime soon, but she has said to me, if I decide to have a child, I'm going to have to move out of Texas. There's no way I would risk it. I'm not going to do it. So my daughter, she's going to go out somewhere.
And I've had patients who have literally moved out of Texas since these have come through, and they love New Braunfels. They love the community. Some of them have deep roots in the community, and they are leaving because they're of childbearing age, and the what ifs are so big.
Talk a little bit more about what the medical schools are doing or not being able to do.
So in your medical school training, you are supposed to get comprehensive medical education. As an obstetrician in residency, so you go through undergrad, then you go through graduate school, then you go to medical school, then you go to residency, and then you might go to fellowship. So there's a lot of steps in there. In medical school, you are supposed to be trained in the full gamut of all care, from everything from histopathology, which is looking at slides, all the way to delivering babies and doing surgeries and doing all of that. In Texas, those medical students are not given the opportunity in Texas to be able to get comprehensive training on medical care. And so some Texas medical schools send their students to California, New Mexico, to other places. But the amount of cost to that medical student is already astronomical. But then to add having to uproot your life, because many of us start our families when we're in medical school. That's the ages of having a family. will not want to spend that money and the time to uproot from their family and go live somewhere else for a month or two to be able to do that training and then come back. So just don't go to medical school in Texas. So we've had medical school admissions have stayed stagnant or decreased, but the quality of those people being admitted as students, not to say that we don't have great medical students, but the quality has certainly gone down that we're seeing in testing scores for Texas and other states that have these bans in place, because the people who can choose to go somewhere else. The same thing though happens with residency. So for family medicine, we have comprehensive training. For OB training, they have comprehensive training. And so the same thing exists. The resident, you're paid a minimum wage and not for the number of hours that you work to be in residency. So you don't pay the residency pays you, but it's less than working at like McDonald's. So it's not a big salary, but it's enough to be able to pay for your room and board. So that cost is factored into having to go to another state to get that training. But in order for a program to be accredited in those two residencies, in those two specialties, you must be providing that comprehensive training. So what we will end up with are physicians who no longer can provide this care, even I don't have the state up, but in those gray areas where we have family docs going out to the communities, the rural areas, they won't be trained in the care that is necessary in an emergency in about 10 years. We just won't have physicians who are trained to do that or feel comfortable or competent in those care issues. So that's down the road what we're seeing if we don't make a change now.
Okay, this is really a morbid question, but it has the fetal heartbeat thing. So if the fetus is no longer have a heartbeat, does that change anything?
Yes. If we can confirm that there is no fetal heart rate, then the rules change so that we can assist a mother with that care if looking at it overall. But the fear from both the physician as well as from the hospital system has still limited that care ability because the laws are gray and unclarified. So the risk department would just rather that woman went home and presented at somebody else's hospital.
Right.
So even if there's not a heartbeat, because there could be somebody that says, well, but you were involved in this, and we found out that actually she took something before she came to your hospital, and that's why there wasn't a heartbeat, and you guys are involved in that care, so you should be sued too. So the risk departments of the hospitals are not supportive of the medical care that might need to happen in that case.
Are hospitals also encouraging the legislature to change the laws?
Yes, the Texas Hospital Association is part of our advocacy effort, along with the Texas Medical Association and each of the individual specialty organizations, the FAAFP, the Texas chapter of ACOG. All of us are working together to try to give those examples, but that also right now takes a back seat to all of the other things that the Texas legislature is fighting for or against. And so while maternity care is a huge thing for those of us who are doing it every day, money, school vouchers, all these other things are also huge things that affect many people. And so it's not taking the front seat that we wish that it would. And in fact, the Texas Medical Association has a program called First Tuesdays. So the first Tuesday of every month, we have white coats on at the Capitol. We all go and descend upon the Capitol, talk to our legislators, and talk with them about various things that are medically based. On that priority list, maternity care, until we, meaning some of us in the specialties, said something, it wasn't even on the priority list. They spoke to it, but it wasn't on the priority list. Scope of practice, funding for different programs, those types of, again, money is farther up on the list, unfortunately. Not recognizing the long-term implications, access to care, quality of care, that are being affected by what we choose to do with this legislative session.
Is there a way that you could find a sympathetic legislator and help write a bill that would just say, please trust, and at least get it free open and people can, march for it or something?
So there are boots on the ground efforts to do that. There's a group called the Texas Coalition for Mothers that is a nonpartisan group that started in Dallas and is now throughout Texas, where they have the ear of various legislators, including those that proffered Senate Bill 8, to get them to change that. So it's not happening out in the open.
Okay.
It's happening behind closed doors, yes. But if somebody has access to a legislator who's willing to put their seat on the line by having one of those bills be proffered by them, that would be a wonderful unicorn in this legislative session. I would love to see that person and talk to that person.
I'm just wondering if there are any examples, since we've also had, for example, hospitals being sued for malpractice for not providing care. Like, would it be the case that the doctor that is sued if the mother dies or for not providing?
So some of those cases that I mentioned that are in the Washington Post and the New York Times, are exactly that, where the physicians are being told by the Texas Medical Board, oh, you should have acted, and they're being sued for not acting. You can't win. You either act and get the civil penalty, or don't act and get a civil and possibly criminal penalty. So it's a really difficult place to be.
I was going to say that gives the hospitals quite an incentive to say, please go somewhere else.
Right, and hands off. You choose to do what you do, doctor. We're not supporting you. We do want you to do it, but we won't say that we're going to support you.
We've had women that have come in to the ER from prison that were actively miscarriaging, and they were like, you get out of here, they needed DNC. And DNC equipment evaluation at Fairtouch with, I think, it's locked up. First department tells you. Prior to this, I did assist with, when we have our boy, I assisted with him. Sometimes SciTech doesn't work. You need to go in there and remove twice a conception, which is usually placenta. They'll continue to bleed. But they came in through the ER, the doctor sent them home. And I can't remember if it was up in Amarillo or if it went to the surgeon. They said the doctors don't have to follow the Tala for pregnant women. Something about that, they could send them home for that one. It was.
So we do have to follow EMTALA,
Okay.
even in those situations, but there are criteria that can be met for a patient to be considered stable enough to go home and follow up as an outpatient.
Yeah.
And that's what those cases were leaning on. On paper, or electronically, but on paper, the woman didn't look as ill as she was. Those of us in the biz, those of us who do this, know that these women are beautifully young, healthy people. So until they get to a certain point, they look great.
Right.
And then, oh my goodness, they drop and they are near death.
Right.
And that's the terrible travesty of this, is that you could send somebody home because maybe her vital signs aren't all that off.
Right.
But she's hemorrhaging, but she doesn't have an elevated heart rate enough. She's not febrile yet, so she doesn't meet those criteria.
Right.
So the risk department can say, no, she looks fine, send her out.
Right.
And you know that within 8 to 12 hours, she's not going to be with us anymore. And that's why I highlighted the case where a woman delivered in the bathroom of the ER because they were sending her home.
Right.
Because they were not willing to put their license, their hospital license, their whatever on the line,
Right.
because there was still a heart defect.
You've said several times about the legislators follow the money, or money's important, those sorts of things. Do any of these people understand the long-term economic impact to the state of Texas?
They have been given the long-term economic impact by those of us in organized medicine, but they are focused on the now. They're focused on the votes. They're focused on the perception in the social media, because social media is typically for the one-liners, the gotcha, and it's not sexy to talk about access to care in 10 years.
Right.
So that's not what their focus is. Behind closed doors, oddly enough, they're actually rational people. You can talk with them, and they are interested in making it better, but they turn it right around and say, but I have to save face. So whatever we can do, I'm in support of making this a better place because I have a daughter, a wife, whatever, living in this state. I want this place.
Computers and play area will be shutting down in 15 minutes. The library will be closing in 30 minutes. If you have materials to check out or need to get a library card, please come to the help desk now.
There we go. Help me to make this, or I'll help you, I'll listen and be ready to make this change, but I also still have to look good. So I will make that change if you can make me still save face, look good to my constituents.
Right.
And it's not the long-term aspects that they're looking at.
I'm sure they're all thinking about what happened in the primaries last year.
Certainly.
Is there any concern about the statistics with the infant and maternal mortality rate going up? I mean, are they concerned, we're probably ranked close to the bottom?
We are ranked close to the bottom. When you look at the infant mortality also, we have this lovely decrease in line, and then there's this sharp increase just in the last 2 years. And so we're going to see that continue to happen. And ours is becoming above the United States. Texas is becoming above the United States. Whereas before, if this was the United States, we kind of hovered below it, and now we're becoming above. So there's, again, awareness of it, but it's amidst the noise of so many other competing entities. So we can be the loudest about their priority. So we need to make it their priority. And the way to do that, I think, is to bring their own experience, their own idea of humanity into that consideration. Because money is money, but if you think of it from the standpoint of you've got a daughter, if she became pregnant and something happened, would you want her to potentially lose her life? Or would you want the physician to be able to intervene in a medically appropriate way?
Right.
When we can get to the person in that way, we're much more likely to be successful, because then it's not about the money so much as it is about doing the right thing.
Right.
So the positive, just gonna bring it up.
Yes.
People are interested in making some change, okay? So I like to end things on a positive. I appreciate you guys listening, and I hope that this will encourage you in some way to reach out to our legislators, because if they hear from you, you're a person they want to impress. So make sure that they do hear from you. There are speak outs everywhere to be able to reach our
And don't forget, LWV Texas has a wonderful take action tool, makes it really easy to find the contact information and even to send a quick email on, although they also include the phone number, so you can text if something does come up in the legislature.
And when it comes to bills, it's kind of strange. Their staffers really do have a tally of how many they have on the yes and how many they have on the no. So individuals make a big difference. So very much as we see bills come through, keep track of it and write a note and just send in I disagree with this. That's literally all it has to say. And
This is
then
a
we'll check it
priority
out.
issue for the League in Texas. So you will be seeing action alerts if there are any. I know Senator Gutierrez does have an amendment that he's filed promoting reproductive choice. But I think we really do need to address removing the restrictions on doctors.
Do you have a sample, I mean, as a medical board or somebody, written something that would work?
All organized medicine has been very careful on being transparent with that at this time because there are so many competing interests in organized medicine also that if we make this one thing the thing, we might lose all these other legislative opportunities. So I know that's an excuse, but that is why that does not exist. ACOG at a national level has some verbiage that they would suggest, but they don't have anything for the Texas district because they don't want to shoot themselves in the foot when it comes to conversations with various legislators who might have proffered the bills or might have supported the bills. But ACOG is a great resource for that. Well, thank you guys.
Thank you.